Hello and welcome to another episode of the AABIP podcast. This is your host, Udit Chadha from Mount Sinai in New York City. Today, I am very fortunate to be in the presence of Ryan Macke. He's a thoracic surgeon at Banner MD Anderson, and with him, I'm going to discuss management of hemothorax. Ryan, thank you so much for joining me today.
Thank you for the invitation.
With regards to this topic, do you have any relevant conflicts of interest to disclose?
I do not.
And I must clarify, like with every podcast, the views expressed on this podcast are those of the speaker and mine, and not necessarily those endorsed by the AABIP. So let's get started. So Ryan, you are called to assess a patient with a pleural effusion that by the clinical history, the CAT scan, the ultrasound, whatever, is definitely a hemothorax. The patient, though, is hemodynamically very stable. What is your threshold to drain the space? And do you start with a thoracentesis in a very stable patient?
And so I think this is a situation we see from time to time. And I think this kind of, the history is always important, trying to figure out if there's any blunt trauma, any instrumentation, or any trauma at all, any intervention that may help clarify what the cause of the hemothorax is. And then also, if there's any coagulopathy, if the patient's on anticoagulation. Mm-hmm. But typically, if there is clear evidence of a hemothorax, I think it should be drained. The timeline or chronology of it is important. So if it looks very heterogeneous and like there's clot, that is going to kind of factor into how I would manage it. But in regards to the question of thoracentesis, I would say that I strongly discourage thoracentesis if there's any question of any hemothorax component. Mm-hmm. I think in these situations, hemothorax should be evacuated, and so your options are either tubulotomy or surgical drainage. But thoracentesis, typically, if there's clear evidence of hemothorax, I think only delays the necessary therapy in the long run.
So in someone who's hemodynamically stable, do you still consider either or, tube thoracostomy or surgery, or would you in such a situation try a chest tube first?
So I think this is one of those where you definitely need more information. I think that if this is, if it looks like there's a lot of clot, then I would be more likely to just say, let's just go evacuate it, do a VATS hemothorax evacuation. If it looks like it's not yet clotted, it's could potentially be free flowing, then either a large bore image guided pleural drain or even a bedside chest tube, I think is a reasonable first step. The hemodynamics, obviously, if you're dealing with trauma, hemodynamically unstable, that's a different situation. In this scenario, though, I think if it's free flowing, getting a tube in, every once in a while you will get, I guess you could call it lucky, where the tube goes in, it does evacuate it. But if there is clot, then or clear evidence of clot, sometimes it's better to just pull the trigger and operate. Now, you have to factor in what other things are going on with the patient as well, how frail they are, and if they have other injuries, or if they're being treated for cancer, things like that. That may lead me more towards putting a tube in. And there's always discussion of fibrinolytics, and we debate that a lot within our own group, because there's some concern about trying fibrinolytics in hemothorax and causing additional bleeding, or if there was bleeding that stopped, having that restart again.
So again, just to clarify, so if you see clot, your threshold for surgery is lower. If you don't see clot, it's free flowing, or they're a borderline surgical candidate, you'd rather put a large bore chest tube in first, correct?
Yes.
And what is a large bore chest tube? What French are you talking about?
Yeah, so another tricky question. So, when we're talking about trauma and things like that, we're talking about like 36 French chest tubes and big chest tubes. In situations like this, when I say large bore, I'm usually, if it's a hemodynamically stable patient with a small to moderate hemothorax, I would be leaning on our interventional radiology or IP colleagues to, do an ultrasound guided tube pleural drain, and then when they say how big of a tube, I say the biggest one you have. So
Mhm.
I think the largest one that we have is a 21. I think there may be larger kind of pigtail, large bore tubes, but I always ask for the largest one whenever you're dealing with a situation like this.
Mhm. Okay, so let's say you put a tube in and
Mm-hmm.
some amount of the old blood drains out, and there's
Mm-hmm.
a small residual collection,
Yep.
right? And I guess we don't worry too much about a very small residual collection. But let's say that after tube thoracostomy, there's a moderate residual collection. Now, what is the next step? Surgery in a good surgical candidate, and when do you consider TPA in these patients?
Yeah. So I think that one scenario would be that this is, a moderate hemothorax. Let's say it was you have minimal concern about contamination. For example, let's say it's an old person who had non-displaced rib fractures, had a little hemothorax associated with it. No instrumentation, no concern for introduction of bacteria.
Mm-hmm.
That's a different scenario than, one where there's instrumentation. You're worried that could develop into an empyema. But
Mm-hmm.
hemodynamically stable, good operative candidate with residual hemothorax, I'm almost always going to go to the operating room and just clean it out. I think that's going to result in a shorter hospitalization. It's going to clean out your pleural space. And typically your tube's only going to be in for a couple days after that, and they get out. If it's a borderline operative candidate, if it's someone who's very frail, has other things going on, you're worried about taking them to the operating room, and it's a small to moderate residual, you can try TPA. Like I said, we debate this quite a bit. I think you have to be prepared to, if you try TPA and either it doesn't get it all out, or you do get it out, but then there's ongoing kind of bloody drainage, then you may be going to the operating room anyway. So I would say your first line is always try to operate if you can in those scenarios. But if you're going to use fibrinolytics, you just have to be careful. And, it's not one of those where I would give TPA at 5 p.m. and go home. I would give it and keep an eye on that patient. And I'm sure we've all seen too, where, you do TPA and then the nurse unclamps the chest tube, and then it's, really bloody stuff coming out, and everyone starts to panic a little bit. So it could be a tricky situation. So, but most of the time, I think in these scenarios, you are able to operate, but there are certain circumstances where you have to consider fibrinolytics.
And what dose do you use of TPA?
So another good question. Typically when we're doing intrapleural TPA fibrinolysis for loculated effusions, and I'm usually using 8 milligrams of TPA and then Ordonez. But in this scenario, I've used 4, I've used 8. So sometimes I'll try a lower dose if you're a little bit anxious about trying the TPA in the hemothorax setting. But again, I think it does come down to what is the etiology too. I mean, if you have like some rib fractures, you do the TPA, are you going to break down the clot, then it starts bleeding again and things like that. So you have to take that into consideration versus, or let's say someone had a thora where they hit the intercostal, are you going to knock off that clot and have it start bleeding again? So again, you have to be kind of careful in the scenario that you're using it.
So TPA is the clear second choice in somebody who you want to evacuate completely with a residual collection after tube thoracostomy. Now, you take the patient to the operating room. I presume most of these start off as a VATS, right? Unless there's something else that's going on. What's your goal of the surgery? Is it just to completely evacuate the space so that you prevent fibrothorax and a potential empyema?
Yeah, so I think most of the time that is what we're doing. So whether it's a, post-operative hemothorax, say we did a lobe or something, or a, iatrogenic one or one from rib fractures, most of the time you're going to go in there and you're not going to find any clear source of bleeding, and you just want to get all the clot out. I think it's very important to make sure you do look and try to find a source. Because you hate to go back a second time. And so removing all that clot, fibrinous stuff. And I think you also need to be conscious of sometimes if it's more advanced, say it's, you're a few days out or a week out, there may be a bit of a fibrinous rind on the lungs. So you may get all the clot out, but you need to make sure that you're decorticating the lung as well, so that you can get lung expansion and good pleural apposition.
So if I can just stop you there. So in the empyema world, right, the people who favor an early surgical approach over early lytics and Dornase give that argument sometimes that, if you operate early, it's probably an easier operation than doing it a week later. So is that same logic applicable in the hemothorax world, that operating early may mean that you can just evacuate the space, you don't have to deal with decortication or anything like that?
Yeah, I think that's accurate. I mean, the clot becomes, it becomes more fibrinous, and then you're peeling more stuff off the lung, and you increase the chances of, having little parenchymal tears, and having it be less organized. So yeah, I think earlier is better, but sometimes we don't have that luxury, and that, the patient may show up a few days later, or like I said, they may have other things that are more pressing that have been going on. You don't have the luxury of going in day 2 or 3. Instead, you're sitting there at day 6 or 7. But yeah, sooner is certainly easier in terms of evacuating everything and having a greater chance of good pleural apposition from lung expansion.
So again, the opposite scenario to what we discussed in the start. Let's say someone has a traumatic or iatrogenic hemothorax and is hemodynamically unstable. Obviously, you want to stabilize them in every way you can. But I guess your approach would differ, that this has to be a surgical first approach, correct?
Yeah, I mean, I think if you have hemodynamically unstable, but usually in those instances, you have some sense of what the etiology is. But I mean, in the
let's say a thoracentesis. Let's say we do a thoracentesis. You hit an intercostal. You put a chest tube in right away, but it keeps dumping. You're resuscitating the patient. Blood pressure's dropping.
Yeah, I think there's no role for. Yeah, that is clearly an operative. You go to the operating room. I would not jump to a thoracotomy in that setting. I think most of those can be handled. I would also not do these cases robotically, just because if you are dealing with, worried about bleeding and needing to convert to a thoracotomy, you can convert after robotics. But in these instances, I think it's more straightforward to do VATS. But yes, in those instances, I would go straight to the operating room.
And is there any role in consulting IR in these situations?
I think that would be a very rare instance where, you would, if there was some reason that you did not want to go to the operating room, but embolizing an intercostal can be done, but I think the amount of time it would take to mobilize and get that done, I would say that it's a less common. I think it would have to be a very unique situation to go that route.
Awesome. Thank you so much, Ryan. These are all fantastic answers to what I think are really tough questions, but your answers have been detailed and very, very educational for, I'm sure, me and everybody else who listens to this podcast. I don't have any further questions. Do you have any comments that you would like to make? Something that I've not touched upon?
No, I think it's a good discussion, and this is something that we talk about as chest surgeons and with our IP colleagues and our IR colleagues frequently. So I think a multidisciplinary approach and looking at the timeline of things and using all the tools, but when you can, in the world of hemothorax, I think when you can, just evacuating it is and the sooner the better is probably the main message. So yeah, good questions and great discussion.
Awesome. Thank you so much for your time.